the day and abstract, so I'm not going to go into the methods. But we looked at the current use of digital platform for integrated disease surveillance in Oyo State. The challenges are linked with the deployment, and then we assess the usability and organizational requirement. We use the human-centered design to be able to interrogate this. Now, in a few sentences, I will just go on to highlight the lessons that we learned. We found out that in Nigeria, during a desk review, we identified at least 12 digital tools and platforms that are used for infectious disease surveillance. And many of them were not speaking to each other. And in fact, many units and departments were not aware of the existence of the other units using such tools like that. Now, the lesson is that when we're introducing things like this, multiple partnerships, communication, collaboration, and coordination using the One-Net approach is always very, very important. The second lesson was that when we use the system usability scale to assess the ability of users to be able to navigate and to navigate around the system and also to be able to use it without difficulty. It was learned that the learnability, which is the ease of navigation, and the use was poorest for SOMAS, was a bit better for DHIS2. And it was better and because of this difficulty, many of the users often migrate to, open data kits, WhatsApp, Excel-based applications because of their difficulty with navigating around the SOMAS. So the lesson here is that user experience and feedback must be used to guide design. And we must have an opportunity to get these user feedbacks even after we have deployed, a design so that we can redesign as necessary. The lesson 3, we found out that contrary to assumptions that SOMAS would improve the timeliness and completeness of reporting, we found that only in 61.3% and 58.1% of local government areas, respectively, had improvement in timeliness and completeness after this introduction of SOMAS. So the lesson here is that assumption of digital tool effectiveness cannot be held in vacuum. We have to consider other factors, and so monitoring and feedback is always very, very important. Our lesson 4 is that there were technical challenges which included offline and online synchronization, threshold or data overload, poor supportive supervision, and the organizational challenges were the lack of a data transformation strategy. None were aware of that, and many said that what they do is that they adopt whatever external bodies bring in. And so they do not own the infectious disease surveillance space and rely on external forces. So the lesson from there is that online user support or troubleshooting tools, as well as supportive supervision and constant training, are needed for digital tools to be very, very effective. The last lesson, lesson 5, is that digital tools are adaptable for community surveillance, but with limitations. And these limitations will include internet subscription, access to electricity, and unclear engagement rules. So the community expressed this, that the rules of engagement are quite unclear. So the lesson is that for us to be able to use digital tools, devolve it to the community level, we need to have clear-cut rules of engagement. We need to have training and retraining, and we need also to build community trust. So I'd like to conclude that structured transformation strategy is the way to go, because this would contain all the lessons that we have put together. It will guide the national, state, and local adoption of digital tools for disease surveillance and response, including the development of appropriate tools for community informants. Thank you very much.
Thank you very much. Let's put our hands together for him. All of them are still within the time allotted. Now we'll go on to the panel discussion. which will last a few minutes before we now allow others to make comments and ask questions. I will start with Dr. Okunromade by asking, what are the digital tools available to us in Nigeria currently for infectious diseases surveillance? How effective are they? And then how can we improve on them?
Thank you, sir, for that question. For us as a national, Nigeria has adopted digital tools for surveillance of public health events. And across all levels in the country, both at national, subnational, and the health facility, the point of entry, as well as the laboratory, we have deployed, there's been a lot of tools deployment across these different levels. Dr. Adebi presented well over 12. Well, I would say that we have over 20 different tools being deployed at different levels. But the main thing is that they don't really speak to each other. But I would touch briefly on the main 5. We have what we call SOMAS. This is the main tool deployed by Nigeria for public health surveillance of infectious disease. Is for immediate reporting of case-based diseases. For SOMAS is an open source and it supports real-time disease detection. SOMAS is for outbreak response management, for contact tracing, as well as for it's also been it has been deployed at the point of entry as well. For SOMAS, in terms of efficiency, I would say SOMAS supports real-time notification of events. So any occurrence of any outbreak or public health event at any level, every level of decision-making gets being notified, and action is taken appropriately. Also, we use it to manage contact tracing so that it's very easy to link a case with contact, and also for contact follow-up. For case management, when there is an update on each case, it's easier for clinicians as well as the state epidemiologists and the surveillance officer to get notified of any update on what is happening concerning a case. And this also has improved the case management during outbreak response. And also it's a good mechanism for feedback across each level. And I would also talk about DHIS tool. DHIS tool is also a major digital tool that has been deployed for surveillance. But DHIS tool does not support a real-time notification of public health events. DHIS tool aggregates a monthly reporting of cases for IDSR 003. For some of us are familiar with IDSR 001, 002, and 003. Also, we have what we call MSAS. MSAS is a mobile SMS platform, which is used for also aggregate weekly reporting. And also the advantage of the mobile MSAS platform is that it's very easy to use at the community level where the data network is very limited. And also it aggregates cases at that level. For us, we also have what we call event-based surveillance. This is used for early alert and signal. It is an AI-driven system that is used to that is actually used to mine information across social platforms to escalate rumors or signals or events that can cause a lot of calamities within the community. So in terms of the key challenges, as I've presented, the major challenges that we have concerning these tools is funding. In terms of funding for devices, update of devices all at subnational level. So subnational level, we need the state, the LGA, to be able to hone and fund their surveillance system. There's been a lot of over-reliance on donors as well as the national. Even at the national level, a lot of reliance on donors. So the government needs to ensure that there is enough funding for surveillance within the health security system at every level, in terms of funding available for data, funding available for procurement of devices, and also there is also a capacity challenge. There is a poor digital literacy across every level. There is need to ensure that we keep a continuous capacity building exercise across all the state at the LGA level. And most importantly, there is need for the country to have what we call a digital surveillance governance policy. This will help at every level, or every organization or platform that want to develop or introduce a new digital system, to be able to have a set of standards and protocol to key into to protect data privacy as well as the data ethics in the country.
Thank you very much. I think you just did the summary. Left to, if we allow you to take another 30 minutes. So let me go to Dr. Simpa with this question. Mobile health and telemedicine is the in thing now, and we know that it can be quite helpful in the control of infectious diseases. How much of this have we deployed in Nigeria? And what are the achievements so far?
Interestingly, I think the way to look at it is between the public and private sector. On the private sector side, which is largely driven by entrepreneurship and that's happening, but I don't think it's at the rural level. I mean, so technology diffusion, right, kind of follows money, right, and it's explainable, right? It's just the cost of acquisition. Just we talked about devices. So just like when telephones, mobile phones first came in, right, you had very high network people. Network people use that, and it took a while before Globe came and then it came all the way there. It's the same way that's happening. So we're at that level now where it's really being driven by the middle class use, right, and not yet at that very rural, point. Now, when it comes to the public sector, there are very few subnational programs that exist where telemedicine is being used to drive stuff at the rural. I think Lagos State did a pilot. And then you had some also around FCT, as well, and then some also in Kaduna. The thing also is that most of these pilots are driven by donor funding. And so once that funding ends, project ends.
Thank you very much. Let me go to Dr. Adebi. With the Nigerian health workers, what's their capacity to take on these digital tools for infectious disease surveillance? What is the gap like? Is it so wide? And how can we fill the gap?
Yeah, so we came up, when we did this study, the immediate feedback was that there are a few of the workers who are not trainable according to the feedback that in terms of digital tools of what we got back. But when we took this to the advisory committee level to interpret some of the results that we got, we realized the fact that it was not that they were not trainable, it was the deniability of those tools that had a problem. That is the ease of the ordinary user to navigate without difficulties. So whatever tool, digital tool that we have, it's not that our workers cannot use it, but because we do not factor in the user experience. So whatever it is, we find market women using WhatsApp that had no education at all. So if they can use that, because initially, what we found in literature is that there are some, the capacity of workers to use these things are very poor and what have you, but our quantitative study, which we had not even analyzed when we talked with the Committee Advisory Board, where it's only the qualitative study that they were interpreting for us, made us understand that it is the deniability that is a problem. And this was reinforced by the findings from our quantitative study, that is actually deniability that is a major issue.
Okay, thank you very much. Let me get back to you, Dr. Kurumade. With the deployment of digital tools in the public health landscape in infectious diseases in Nigeria, how well have we performed with types of disease surveillance?
Okay, thank you, sir. I would start by saying for Nigeria as a country, there's been a tremendous improvement in surveillance system with the rollout of the digital surveillance tools in the country. First of all is the country joint external evaluation score. As at the time we did the first JEE, where we had a score of 39, there was no digital platform for the surveillance system. And for those of us that are familiar with the JEE score, we had a score of 1 in the reporting system in Nigeria. But by the time we had the second JEE, we recorded an increase from 1 to 4, meaning that this digital tool has been rolled out across all the country and all the LGA. And that was quite significant and was part of what increased our score from 39 to 54. Secondly, a lot of improvement that has occurred, it has increased our real-time case detection as well as case reporting and outbreak response management across the country. There's been an increase in how we manage our laboratory and the case management information sharing system across the platform. And most importantly, there's been, we have instituted the border health screening at the point of entry, which has made it a lot easier to track passengers that are coming into the country and also to track and monitor potential imported of cases in the country. To give an example, I would touch base on SOMAS and COVID. I know my time is up. SOMAS and COVID-19. With the rollout of SOMAS, we were able to easily detect the hotspots, LGA hotspots in the country, and that also helped us to reprioritize our intervention and to institute what we call the active surveillance case search across the hotspots in the country. And with the use of surveillance, it's part of our success story. We're able to do and aggregate and put out our daily COVID-19 daily reports on all the social media in the country for 2 years. Without that, this wouldn't have been possible. There would have been a lot of delay in reporting, but with SOMAS, that gave us an edge to have a real-time reporting system. Thank you.
Thank you very much. If I allow you, you will not allow us to go on tea break. Let me go to Dr. Simpad. There's a lot now about AI, globally and even coming locally now. To what extent have we been able to use this when it comes to applying for disease surveillance in Nigeria, or what is the potential?
I mean, there's a lot of potential, right, for the use of AI, right, within that disease surveillance space in predicting, you know, what next hotspot would be, in what new disease actually is coming out, and doing that. But you must also remember that surveillance is a state project, right? Which is very different from, you know, say, consumer-facing thing. So it's within those institutions, so like NCDC, that you will see that application, you know, growing. And I believe that there's a lot of initiative that's going on internally to drive that. A few academic institutions, you know, of course, you know, participating and you know, driving it from that point. But I think aside from what we've done within this, there's very little private enterprise looking at that space and saying, okay, what can we do as a product to change that?
Okay, thank you very much. Our time is fast spent. Let me ask Dr. Adebi. We've talked about the community part of it. How do we use these digital tools to improve awareness that will strengthen disease surveillance, infectious disease surveillance?
When SOMAS was designed, I think it was designed to be, you know, an all-comers thing that there could be add-ons. People use a lot of simple tools at the community level. I think what can be done at this level is to look at add-ons that can be interoperable with SOMAS, so that the onboarding of information from the community level will be seamless and will be easy. Instead of developing newer tools and introducing newer digital technologies, people use voice notes, for example. And I was surprised to find out that even those who are not literate at all, send voice notes, everywhere. So simple things that can be adopted at the community level can be add-ons to SOMAS. We already have SOMAS. So we can have those add-ons, and it makes our job easier to get information from the community level.
Let me add to this to say, with our local languages, how can we use these digital tools to improve awareness?
I think Dr. Simpa and I had been discussing about this a lot, and we've been talking about what models are applicable that we can, adapt for local languages that probably may be able to translate some of what we find, or use icons, which community level people can be able to understand. But I think the space for research is huge in that area. And we are really exploring that. We have a few products that we are testing, and we think that with time, we should be able to come up with something that will be useful in Nigeria.
Oh, thank you. I think I will just take the last question. It's not the last that I have here, but in view of our time, yes, before we go to the audience, ask Dr. Simpa about innovations. What digital tool innovations will move Nigeria up, scale up Nigeria up with disease surveillance?
So the tool has been chosen, it's SOMAS. So it's the add-on to SOMAS now that I think that's where the innovation should come in. Just like we pointed out, can we plug in from the community level, to SOMAS? Can we make things easy? How do we improve that learnability and usability, at that level? How do you also ensure, because one of the things that we also discovered again in another study is, like, for instance, private facilities don't participate that much within our disease surveillance system, especially except designated, and which are very, very few. And if you look at all the outbreaks that we've had in this country, they've actually started out from private facilities. So I think those are the things. So if you're thinking of, like, for instance, connecting an EMR, to be able to speak and report directly into SOMAS and stuff like that, and providing notification, yeah.
Okay, you are itching to add in 30 seconds.
Okay. Thank you. So for us at National, I quite agree. We are advocating a lot of add-ons. But for us, what we're actually looking at is interoperability. So there are other digital tools. How do we ensure that we are able to link this seamlessly with SOMAS, which is the main tool? We've started this process with the DHIS, we've started with the NADIS, which is for Ministry of Agric, we've started with Ministry of Environment, but the advocacy is to ensure that every other platform also come on board and be able to link and share data information seamlessly across different platforms. Thanks.
Thank you very much. Now I go to the participants. If you have a burning question, comment, and then you will be the determinant of how soon we will go for tea break. Yes, one. Then I think I can see only one. Oh, there are so many. I can't see well. Can you help? 3. Help me with the numbering, and then, 4. Okay, can someone take the mic to the 4? So we'll stop at 4.
I'm Dr. Innocent Allen Ogena from Edo State. My question is to Dr. Adebe. In your presentation, you told us that you observed that there are too many platforms all going, and they do not even communicate among themselves. what plan or what policy change do you think we should adopt to either harmonize them or ensure that we will have at least a few adopted platforms? Because we recall that in times past when we had so many donors at national level, there was now this issue of basket funding. How do we regulate the so many platforms that are coming on board? That's the first question. Then the second one has to do with Professor, the session chair talked about the whether the capacity of the healthcare workers. And in your response to it, you talked about learnability. But there's something we have observed at the community level. There are some of these health workers that appear to be either untrainable or they don't seem to understand anything. And this also brings us to the fact that in terms of medical practice and in terms of healthcare delivery, the medical doctor should be incorporated into the training of healthcare workers. Because in the history of medical officers of health, there were always medical doctors in any institutions where you had the training of community health extension workers or the environmental health officers. So if we ignore the training process of these healthcare workers, it definitely will fall back to us because of their inability to perform their jobs.
Thank you. The next person, let's address the questions before they respond.
Oh, thank you very much. My name is John Oladejo from CDC. You know, as a matter of fact,
are you contributing? I'm sure you are contributing, not question.
Yes.
Yeah. Okay.
I just wanted to talk about these digital tools we are talking about. As a matter of fact, the Honorable Minister set up a committee, not quite long, to look into all these digital forms. You know, I was part of the meeting where a company called Trek Secure actually came to introduce themselves on this, and they have been in about 20 countries, so that all these digital tools we are talking about, they will be able to speak to one another, so there will be a sort of operationality. So this is very important, and I believe Aphpn should be part of it, because you know, without digital tools, without this AI, I don't think we can move to any level. Thank you.
Thank you. Next, number 3.
Yeah, thank you. I'm Michael Adedoyin from Ogun State. I have 2 concerns, and the first one is on the accuracy of the data we gather and the use of biometric systems. I'm wondering, you know, we see cases, especially in infectious diseases, we see cases of patients, you know, Nigerians being very mobile, you know, they are diagnosed in one place, they have been captured, you know, and then they move to another place, they repeat the same test and all that, and they are captured again in those places. In fact, some of them, we've seen cases where veterinary and human disease surveillance now, but even we have the epidemiology aspect, you know, having a national program running on that. We have disease controls, the programs, their own parallel data collection, and I'm looking at us bringing those 2 sides together so that we can actually have a more comprehensive surveillance in the country.
Thank you.
Thank you.
Number 4. I think it's, oh, okay, that's, oh, it's getting more than 4 now. Yeah.
I think this is morning. So good morning,
30
Mr.
seconds.
Chairman and the presenters. I want to say thank you. 2 quick questions. One, my name is Dr. Shewenson, OHHC FE. I'd like to ask about accessing the SOMAS platform. Do we need any particular permission? Do I just go online and register? And if we are to access the data, what password or who do we seek permission from? As a lecturer in the department working, do we really have roles in this surveillance? I think it's like a government ministry thing, while ours is just to conduct research, and can we have access to the data captured on it? And then a very quick one. So for a young person coming up, what would you advise? Go study AI technology first and learn something on medicine to do this, or you first have to study medicine and then learn something on AI to do this, considering the world opportunities ahead and the future.
All right, thank you. And the last one in front, my HOD, so that I can get back home.
Okay, thank you so much. You know, I sincerely appreciate all the speakers. My question will go to Dr. Mrs. Okoromadu. You made mention that there are a lot of digital tools that are being used. So I don't see the reason why we have to use so many digital tools when there is one that is functioning very well, because that is just, you know, misuse of resources. Let us try as much as possible to stick to one. And when it comes to surveillance in this country, your agency is doing very great, and the foot soldiers at the lower level, especially the DSNOs, Disease Surveillance and Notification Officer, they are also doing very, very great. But what is the guideline, you know, from the NCDC concerning their selection at the HG level? Because one of the challenges you made mention of regarding surveillance is human resources. Because you discover that you train a set of, you know, DSNOs now. When you go back in the next 3 or 6 months, there is maybe political interference, and those ones will be dropped, and another one will be selected. And I think, you know, your agency should try as much as possible to have a guideline in their selection.
Okay.
So that at least, you know, we can have, you know, consistent DSNO. It's not that 3 months DSNO or 6 months DSNOs, and at the end of the day, they just go and be bringing those people that are not trainable.
All right, thank you very much. We'll take one question online, and then we'll get the response. Yes, are we ready? It's not loud.
The level of the teaching hospitals and academia. Thank you so much, every other participant.
Can you repeat the question briefly in 30 seconds, please?
No, I said most of the tools elucidated by the center from the NCDC, sorry that I missed the name, how do we adapt them at the teaching hospitals? That's where we are teaching our students, both the MPH, resident doctors. How do we adapt some of these tools? How do we use them?
Okay.
And then the other ones, or do we leave them at the level of only NCDC? Thank you.
Thank you very much. So we'll get responses very briefly, please.
I'm Dr. Ahoma Mbanozuru from Newi.
Okay. I want to thank the audience for those beautiful questions, very insightful. In terms of interoperability, yes, we are aware that the ministry is doing something. The NCDC has been talking about this even at One Health steering committee level. But what is important beyond these ad hoc approaches is to have an omnibus digital transformation strategy for infectious disease surveillance, which Dr. Iladun also referred to as data governance. That will solve all the problems. Without that, new people come on board, they fraternize with external donors, and we begin the problem all over again. So I think that is the right approach. On capacity, we need to have a paradigm shift. Professor Oshibogun, a renowned teacher of teachers, have taught us, and Professor Akonde also have taught us about the right mix and the right fit in health management. The private sector would employ people and fit them to work. The public sector would fit work to people. And that will result in a wrong mix. It will result in a wrong fit. There is nobody that is untrainable. It's just that we have to fit them to their level of knowledge, what they can do, their competence, the right peg in the right hole. That, I think, and we have seen that knowledgeability is very, very important. There is nobody that cannot use digital tools. It is just that which one is learnable for them at their level. And that's what we need to be thinking about. I think those are all the questions that I have. I'll hand over to...
Okay, let me just take off from where he said. So the key thing here is this, right, is that we fit the technology to the people, not fit the people to the technology, right? It's easier for us to change technology than it is to change people. So just quickly want to do that. Accuracy of data, again, it goes just back to that design process, right? And that's part of the findings that we're talking about here, right? How do you ensure that the system produces accurate data and not leave it just at the whims and caprices of whoever is entering that data, you know, at the end of the day? Biometrics for data, I think that's a very long stretch. It's not impossible, but again, it's just about building tools. Remember, all these things come with hardware, they come with cost of acquisition, and you know, you need to then be mindful about that. Career path. So as you go forward, right, AI is not optional, right? So it's not you do one and then go and do the other. No, you just do both of them as you're going. So you combine both the AI, whether you're doing medicine, do AI alongside with it, whether you're doing public, just wherever you are now, start and engage and begin that learning process. Because like I said, 1 week in AI is like 1 year in lifespan. What has happened, like, I mean, just yesterday, just a quick example, right? I was just reviewing some videos. Like, I could not watch anything that was 6 months ago. It was like, oh no, this will not be speaking English any longer, you know. And that's how evolving that field is. Thank you.
Thank you. I'll try to be brief. There was a question talking about duplication of entries when you have a case in a particular state and then I'll travel to another state. So if you're familiar with SOMAS and you're a user on SOMAS, once a case is created with a particular name and details, it automatically rejects another one. And that is why if a case has been recorded in a particular case, and the individual now travels to another state, what we usually advise is for the state EP to transfer that case to another case instead of creating another EP number, because the SOMAS would automatically spot that error and reject. For different platforms available, there are different disease, vertical disease programs. We have different programs for TB, we have different programs for HIV and malaria, and they have systems for collection of their data. Most times, the common one for these programs are DHIS2, and that is why we're advocating interoperability. Through interoperability. There was a question about assessing SOMA's platform. There are users that are created at different levels. Even for us at national, we don't create users for our states. We only create users for our national officers. At the state level, it's the state epidemiologist that is in charge of their SOMAs at the state level. And at the LGA level, we have the LGA DSNOs and the assistants. So you should be able to link, as a teaching hospital, you should be able to link to the particular LGA as well as the state to have access to the SOMAS. And you either be a surveillance focal person for your facility, or you have something to do with surveillance in terms of reporting to the platform. So I will advise that you connect with your LGA DSNO so that they'll be able to put you through on how to have access to the platform if you are one of the surveillance officers within your facility. There was a question about different tools. In terms of selection of DSNOs, we all know that Nigeria is a federated system. We have the constitution. The national does not have the executive power over what the state does in terms of recruitment. Yes, there is IDSR policy that stipulates the criteria and the requirement for the recruitment of the state EPID and the DSNOs, but yet at that, we don't have that holistic control over how the state goes about with their recruitment. So in terms of that, there is a stipulated guidelines through the IGSR policy, which is also due for review anyway. But when it comes to how the DSNOs are being selected or recruited at the state level, that power lies at the state government authority. And the question around teaching hospital, I didn't quite get that well, but I'll still refer that to the LGA closest to that teaching hospital. The NCDC, yes, NCDC is deployed SOMAS, but the states as well as the LGA, they are in charge of their own SOMAS and they are in charge of their own data. So if there is any training that is required for the teaching hospitals or officers, or that is required for people at that level, please kindly link up with the LGA DSNOs. We will definitely get the feedback. But that is how the IDSR framework works. We start with the LGA DSNO to the state epidemiologists, the information flows to the national. Thank you.
Yeah, thank you very, very much. Let's put our hands together for these panelists. And that I want to apologize that we will not be able to take more questions, particularly for those wanting to ask questions online. And what? Appeal. Okay. If he's coming from BOT, we cannot.
So thank you very much. I think I've listened to some question about how the universities can access these SOMAS. We need to build bridges. All of us here, we have, from the universities, we have departments of community medicine, we teach epidemiology. And surveillance is a key thing that is a component of what we teach. We cannot be doing theory, and we don't know the practice. So how do we build the bridges? You have all these tools that you are using. How are we going to work with you? You at least expose the trainers so that they can be able to train their residents and their students. And then how can they also be able to access the data and engage with it? I think that's what we want to know from you. Thank you.
Thank you very much for this advice. Very good. We'll talk. Take the advice first.
It's actually in the pipeline. So part of the digital transformation strategy that I talked about, the plan is to roll out SOMAS at all the health facilities, both at the public and the private, starting with the tertiary health facilities. We've identified of course, community medicine will be our entry point. But it's actually in the pipeline, and we will soon come. And also it's good to also collaborate with Aphpn in this project. Thank you.
And finally, I'd like to thank everyone, all the participants who are here in person and those online. And we want to thank you for your patience. And we end it here. Thank you very much.
Thank you, Mr. Chair. Thank you, everyone. We'll be going for tea. We'll be back 30 minutes time. 30 minutes, 30 minutes, 30 minutes.